intensive care doctor. It's here with us as well, Jean Cohn. She has been a nurse for 47 years. She's been a hospice nurse for 12 years, most of them in acute inpatient setting. Currently, Jean is the director of Casey House. We also have here with us Sharon Klein. Sharon has been with Montgomery Hospice since 2007, and she is the director of clinical access since 2009. She has been a hospice nurse since 1987. Sharon has a background in intensive care, ICU, and CCU. Welcome to our panelists today.
Thank you.
Well, the objectives for our session are we're going to first identify the regulations. We're going to talk about eligibility, and we're going to dispel some common myths, and we're going to offer concrete and practical scenarios for general inpatient care. All of this information is based on 20 years of experience that Casey House has. For the audience, you may not know, this year we celebrate 20 years of being open and servicing our community. And so we're going to draw information from that experience. For the audience, if you have any questions, please type them on the chat box, and we will do our best to answer your questions as we have a conversation here. So don't be shy. Send us your questions. So we're going to start talking about what is general inpatient care. And I'm going to turn to Jean, our director of Casey House, to tell us about it.
General inpatient care is one of the 4 levels of care in hospice. The other one is routine. The other one is respite and continuous care.
Mm-hmm.
General inpatient is a short-term solution for hospice patients whose symptoms require intensive medical attention that cannot be provided anywhere else. And it's always given in an inpatient setting, not in the home.
Mm-hmm. Thank you, Jean. Sorry, I moved in the wrong direction of slides. How is general inpatient care paid, Ms. Sharon?
So general inpatient is paid through if they're a Medicare patient, it's through their hospice Medicare benefit, which is Part A. And it is covered, it's a different level of care, but it is covered 100% by Medicare.
Mm-hmm.
If indeed a patient has commercial insurance, most commercial insurances do have general inpatient or our GIP level of care included in their policies. And that, of course, then is going to depend on what your commercial insurance coverage is, but sometimes and often is paid 100%.
Mm-hmm. Mm-hmm. And I don't think I got a chance to introduce myself because my counterpart got disconnected. I'm Monica Escalante, I'm the CFO at Montgomery Hospice, and I want to say that we get paid at a high level for general inpatient care. In our area, that's around $700 per patient per day, and this is likely to go up this fall. That's what Medicare has announced. But the other reimbursement rates are much lower than that. Okay. Where can general inpatient care be provided? Dr. Coleman.
Well, general inpatient care can be provided at an inpatient facility, of course. It has to be Medicare certified along the way. It also can be provided in a hospital or in a skilled nursing facility, as long as they have 24-hour RN coverage with the RN directly involved in the care and symptom management of the patient. Usually a hospice will do the GIP care at a hospital or long-term care facility if they have a contract with those facilities along the way.
Mm-hmm. So if a hospice does not have its own freestanding inpatient facility, as we do, they have to do a contract with another facility, right?
That's correct. They have to have some access to doing long-term actually to doing acute symptom management, either in a long-term care facility or at a hospital.
The same occurs if a hospital doesn't have a hospice. There's many hospitals in the nation that have their own hospices, but if the hospital doesn't have a hospice and they would like to provide general inpatient care, they have to contract with a hospice, right? Am I correct?
That's
At this
correct.
time, that's true.
Okay.
And they also have to provide, the hospice, whichever hospital would have to provide specialized training to the nurses who would be covering when the hospice nurse is not there to review things. So it's not just regular hospital care, it truly is with a hospice idea. And the idea is that comfort, and they need to be knowledgeable in how to manage those symptoms, because it's, as with end-of-life care, it's really more symptom management that's so important to our patients, because we like that quality of care and quality of life still there.
And throughout this presentation, we're going to go into more detail on what exactly that means. Thank you, Sharon. So, Dr. Coleman, it's our understanding that Medicare doesn't interpret the process of dying as a symptom. Do you want to talk to us about that?
Yes. General inpatient units are used for acute symptom management, pain, respiratory distress, agitation, nausea, vomiting, complex wound care. Generally, those are the indications for it. Dying by itself is not a symptom, and Medicare does scrutinize us carefully for this issue. If a patient is just slowly declining, their respirations are slowing down, maybe they're slightly febrile, if it can be managed in another setting, then that's what they would prefer. That is not appropriate for GIP or general inpatient care. I often liken a GIP unit to an ICU for hospice patients. Intensive care unit is just a place, a way station along the way to get symptoms managed.
Mm-hmm. Yes. So when is general inpatient care appropriate, Dr. Coleman?
Well, it's for those symptoms that we were just describing. When pain management is needed and it cannot be done at home, sometimes that means requiring parenteral or injectable medications. Same with nausea and vomiting. It may require different medications that cannot be taken by mouth, and it needs to be injectable, or even having specialized suctions such as nasogastric tubes. Other reasons for it are respiratory distress, for shortness of breath, can be an indication for it if it can't be managed in the outpatient setting. And for complex wound care that may take an abnormally long time, require specialized dressings, possibly debridement of the wound or medication applied to the wound to bring comfort to the patient.
Mm-hmm. And we're saying not every patient who reaches the end of an acute hospital stay will qualify for GIP.
Absolutely not. They have to have some symptoms that may not have been able to be managed by the hospital along the way, or they're expected to have some serious symptoms from changing their focus of treatment from a curative to a palliative approach.
Mm-hmm. So who is not appropriate for GIP?
People that are not appropriate, who might have symptoms, but those symptoms can be managed in another setting with things that can be used in that setting.
Mm-hmm.
Just because someone is in unsafe living conditions at home, maybe doesn't have an appropriate caregiver, that's not a reason for GIP. If a caregiver has been overwhelmed by the care, but the symptoms are under control, they're not appropriate for GIP. There is a benefit called respite, especially under Medicare, where a caregiver can get 5 days of respite care, and that's what's appropriate for that, not the GIP level of care. And once the symptoms are managed, and we at Casey House have gotten them to a place where those symptoms can now be managed somewhere else, then they're no longer appropriate for the GIP setting. When we've gotten their symptoms managed to a point where what we're doing can be done somewhere else.
Right, right. And from the hospice standpoint, the level of reimbursement at that point changes from about $700 to $150 or along those lines. So, and that happens quite often, right?
And one of the difficult things about that is your documentation has to be very, very accurate about why this patient still requires GIP. And since the people that are looking at our patients cannot see them and see what we do, we have to very clearly explain in the documentation why these symptoms cannot be managed somewhere else, or why their care still requires frequent adjustments and needs to be done in an inpatient setting.
Mm-hmm.
Yeah, GIP care is intended to be short, typically. Medicare, which is the primary hospice benefit provider over commercial insurances, scrutinizes patients often that have long lengths of stay. Generally, they consider that about 6 days, and will go back, look at charts, to see if it's appropriate, if the patient should have been at that level of care.
Mm-hmm. So caregiver breakdown does not qualify for general inpatient care.
Correct, because that's a respite. That's about the family, and so we don't like to keep those people there. It's a level of care that they really don't need, but certainly, they can always have respite any number of times for up to 5 days, and sometimes families are reluctant to do that, but it's just that's not what inpatient is about. It's more of a hospital setting without being a hospital. It's still friendly and family focused, but again, it's just not the place for care, because caregivers are burnt out.
Right, right. So it might be common that once the crisis is resolved, the patient needs to move out somewhere else, right? When they are no longer appropriate for GIP. Can you talk?
And because of that, from the very beginning, even when our liaisons and our admission people, at the very beginning, before patients even come to the inpatient setting, begin to talk with the family about the next step. And then we continue that at Casey House and build on what the liaisons have talked to the families about, that what is the next step? As soon as we get these symptoms managed, where is it they want to go next? And so while it sounds cruel, in fact, they need to start thinking of it right away.
Mm-hmm.
It comes as a surprise to many people that not everyone dies in a hospice house. When people think of hospice, they often think of a place like Casey House, where you go to die, but it is not intended for that. Most of our patients we take care of at home. Casey House, like we say, is really intended for things that we can't take care of at home.
Mm-hmm. And once they are resolved, people need to move out of that level of care and go into a different setting, right? So it's you have to work with the families. It's probably very intensive in psychosocial support for the families to feel this transition time that sometimes, as Jeff said, it's probably they think that they're going to move to Casey House and stay there for the duration, but that's not always the case.
Mm-hmm. Mm-hmm. And especially if the patient really wanted to stay home. So we're really working towards that goal. We want to meet the patient or the family's goals. And so we do provide I know we do. We provide service when the patient goes home that is a higher level. They get more frequent visits to make sure that they're still doing well. They understand the new plan of care and again, focus on what does the patient really want. And can we help make that happen for them?
Absolutely. And if we can honor that wish, we will. So what are the regulations? We briefly touched some of them, Sharon, but can you go in a little more detail?
Regulations are very clear under Medicare guidelines. It is to manage the symptoms such as acute pain, and as Jeff has already said, shortness of breath, restlessness, pain. I always get stuck on pain because that's what we always think of. But honestly, the respiratory distress can be a bigger problem sometimes, and also complex care. And we're not talking about a wound that just takes a once-a-day dressing change. And sometimes we've even had patients with multiple wounds. So it's complex wound care. So it is really to control the symptoms as quickly as we can to get them back out of Casey House, and they can be at home where they should be and probably will be the most comfortable if that's their goal. And when we talk about home, sometimes home is a nursing home or an assisted living because we provide care there, and that becomes the patient's home.
Right.
So,
right.
Again, and when we talk about symptom management, again, it's something that can't happen in the home, wherever home is. We want to make sure that that's it. Because sometimes we do what's called continuous care, another level of care that Jean mentioned. And that's actually care in the home with more, the hospice staff is there up to 24 hours, or as long as it takes, but to manage symptoms. We're actively managing symptoms. And again, as soon as we get those symptoms managed, we're not doing that. We go back to routine care.
Right.
So with GIP, again, the biggest thing is it can be provided somewhere else. That's why a hospice house like this is so beneficial.
And we've had some cases where we've taken patients out of machines. Jeff, do you want to elaborate on that?
Yes. One of the complex types of care that might occur is somebody that's on a ventilator. We will sometimes take patients from facilities or from hospitals or even sometimes long-term care facilities that do that sort of thing and wean them from their ventilators so that they can breathe on their own. Or once they've decided that this is no longer the intervention that they want. So we try to keep them comfortable. Sometimes they do pass away and they do die. Sometimes they don't. And we just manage to keep them comfortable until we move on to the next setting. Same thing with BiPAP, using that as respiratory support along with medication to keep people comfortable, as well as high-flow oxygen, which we'll have the capability to do in the very near future.
We can do it now?
Oh, we can do it now.
Wonderful.
Okay.
Wonderful.
So.
Wonderful. So what are the requirements for contracting for GIP? We need to have a Medicare certified hospice that must supervise the care, right? But we also need nursing in the facility, right? If there's one patient with GIP needs, there needs to be a nurse 24/7. Can you talk about that, Jeff?
Yeah. The facilities that we have, that we contract with, need to have a nurse that's trained, that's present there, an RN that's present there 24 hours a day. It doesn't have to be the same RN, but someone has to be there that's trained that can do symptom management. And the hospice often provides support for that person with daily to frequent visits to help with management in such a facility to make sure that the patient is getting what they need. The facility also has to have a comfortable place for the patient, usually private rooms, and space for the family. Allow 24-hour visitation, including their small children, perhaps, pets. These are all things we already do at our inpatient unit. Sometimes it's more difficult to do in other settings. contract with facilities like that.
Mhm. So it takes a very specialized training and a special person to do this. So Jane, what are the qualities of a good hospice inpatient nurse?
They're really sort of a unique combination of qualities. A good inpatient hospice nurse needs to be a combination of a critical care nurse, because we treat and assess symptoms very quickly, very acutely, and then also they're a good part of med-surg nurse, a good basic bedside nurse, because we don't need technology to assess our patients. We use our eyes and our ears, because we find that's a lot more comfortable for a patient than having a lot of monitoring with a lot of alarms and bells on. And then they're a little bit of a social worker, because even though we have a great staff of social workers there, sometimes the need is so acute, the social worker might not be there right then if it's late at night. And so the nurse has to kind of combine all of these at once to provide a good care in that inpatient setting. Rapid, up-to-the-minute treatment of symptoms, being able to assess them and treat them, and being very comfortable treating the whole patient unit, the patient, the family, friends, doing that all at once.
One of the good things about being at a acute care facility like Casey House is that we often have what are called interdisciplinary team meetings. The nurses, the social workers, volunteer managers, administrative staff, and the physicians, they always constantly interact, to care for that whole person. And that's what we try to provide, because it's more than being about their medical problem.
Mm-hmm. So the training of these nurses has to be ongoing, and perhaps the emotional support to provided to what they face every day. Hospice in general, but inpatient is even more necessary from a supervisory standpoint, right?
Right. Because we so often are faced with things that in a normal life would be very traumatic. Death of very young people, death of someone that reminds you of your mother or your father. The staff is very supportive of each other. We all kind of know about each other, and we know kind of what things are going to trigger us. Our social workers and our bereavement counselors are very good at providing that support, about just kind of going around and getting a feel for the atmosphere, and supporting the nurses and the CNAs so that they can continue to do the work at the bedside.
Right. So we are not going to go into the standard patient areas. This is what the regulations require that a general inpatient care facility offers to preserve dignity, comfort, and privacy of patients. And we're going to show you some photos of our Casey House. Right now you see the entrance of Casey House, but what we really want you to see is the spacious areas that we have for families to congregate. There are some cases where the families are small families, but others when there's large families. I even remember one case when there was a family that came in a bus for some special occasion with the family, and I think we've had officiated weddings and other things like that at Casey House. Also, the rooms are very spacious. The rooms can have family members spend the night there. Sometimes more than one family member. They can accommodate to families given whatever their needs are. And visiting hours are also not restricted. Visiting hours are open and available. And if patients have their pets, we have the doors. How do you call those doors? Dutch doors that allow for the pet to stay in the room with the patient, which brings them a lot of comfort. If we also have pet therapy, pets that come and visit. All of these things combined make for an environment that is conducive to good end-of-life care. And I'm showing the photos of we have a meditation room for families. to spend some time together. We offer tea time for families to kind of bond with each other as well and support each other as this process unfolds. And this is the back patio you have in front of you. The doors of Casey House are built in a way that the beds could be wheeled out, and we've had several stories of patients who want to go outside, and they go outside and then spend time. You want to talk about that, Jean? That's better for you to describe than for me.
Right. The first day of spring probably sees all our beds out on the patio. Sometimes patients have been in the hospital for a long time, and just to be able to go outside and feel the sun on their face, and we move them outside in their beds. We can take their oxygen with them because we have concentrators to use if we need to. Anything else they might need, and it really does the family and the patient a lot of good. People will come and celebrate birthdays there, anniversaries. We've hosted several weddings there of both patients and their family members. It's just a very welcoming. To the very front that you can't see is a fish pond that gives a lot of pleasure, not just to the adults, but to the children. It has quite a group of frogs living in it right now. So it's a very comfortable way, and there's a walkway, the entire around Casey House, that you can walk. And they tell us 10 laps is a mile. And oftentimes our family members go out there to just get a little respite time for themselves.
That's wonderful. We will be offering tours of Casey House. There will be a sign-in sheet and information sent to all of you, the participants, the attendees of this webinar. There will be sessions in July, August, and September, and a way to sign up for them if you haven't seen Casey House and you're interested in a tour, a personal tour. So we are back. And GIP cannot be provided in the patient's home. That was the poll that we were trying to get your feeling if you knew whether it can be provided in the home. There's in the audience today, there's some administrators of assisted living facilities and nursing homes, and we want to say, Ms. Sharon, can you tell us where can GIP cannot be provided?
And I know that they have the slide, correct? So I don't like to read the slide to you, but obviously it can't be in the home. We've established that, and not in an assisted living, also not in a hospice residential facility. A lot of it has to do with staffing too. Staffing for a GIP level of care is quite different from staffing for a residential hospice facility. So they're just not equipped to provide the care, and it's highly specialized, and Medicare certainly has its thoughts about it, and we do follow the rules. Every hospice wants to follow the rules, and same I know with anywhere else. So that's it.
So if we were to contract with a facility to help them provide GIP care, what are the responsibilities of the hospice provider? So I can speak to the first one, which is administrative and financial management. It would be up to the hospice to bill for the care and get reimbursed for the care. That's one of them. But I think the most important one is the oversight of the medical care, clinical care.
And I know that some people that are doing it in the hospital might have contracts, but they're also responsible for educating the nurses who would be providing the GIP level of care in that wherever that situation, such as a hospital. It's you wouldn't take a nurse off of the regular floor and put her into the GIP, taking care of a GIP patient without having adequate specialized training. And that does need to be done. It really is the responsibility of the hospice to do that. And also to make sure our patients really are getting the proper care and they're safe where they are because they're having qualified personnel take care of them. And we do have an agreement, with the patient. When we're doing the plan of care, the hospice plan of care, such as even with home health, they have plan of cares. Ours includes the patient and the family and the folks that are providing the care.
Right. I think one of the big ones is the ongoing training for the staff and supervision. And we were talking about the fact that GIP is 24/7, right? That some of this education needs to happen in the middle of the night. Or, Jean, do you want to talk about that?
The way that symptoms are managed in an acute patient is really 24/7. The focus is very clinical in nature. The staff, the nurses, the providers, the social workers are constantly assessing the patient, whatever that need is that we're trying to fix, for lack of a better term. We're constantly monitoring it, and then we're supplying interventions to take care of whatever the symptom is. The treatment and the interventions have to be very timely. They have to be focused on the symptom, and it can change at every hour. And so the nurse has to be and also our CNAs. I don't want to downplay them. The CNAs are also eyes and ears on the floor with the patient. They all are constantly assessing the patient and then providing interventions. We have a wide range of interventions available to us, done in cooperation with our providers. It's not unusual, especially at the beginning of acute symptom management, that we're medicating every hour. We have our physicians available and nurse practitioners available to us 24 hours a day. Even when they're not in-house, they're very accessible to us because they're well aware of how quickly things can change. Sometimes we bring a patient in we're treating for maybe pain, and during the night an additional symptom of agitation or respiratory distress comes up that we need additional interventions prescribed for. And it's also a matter of treating that patient not just with medicines, but with other interventions, aromatherapy, music, pets, comfort touch, all sorts of touch therapies. It's really kind of trying to figure out what's the best combination of interventions that will handle these symptoms.
Mm-hmm. And it's really a great expertise of the nurses to look for the symptoms and know how to look for them. What's the root cause?
Well, and that's also, as she was talking about the aides that they have, the nursing assistants, truly they do have education, ongoing education about symptom management and disease process, what to be looking for. And often they see things, it's, that they say, wait, I was giving the bath, and I noticed this, and that's so important feedback for the nurses and the docs.
And one thing that is occurring to me is they also know how to talk to families about these issues, right? That's a big part of it, to prepare the families for what's coming.
And since we do it so often, every day, we're very comfortable discussing not only with the patient, but also with the family, how things are going and what the next steps might look like.
Which might be a struggle for staff that is not doing GIP full time, that has to shift from curative to symptom management. That must be a struggle for all the staff.
Right. I think it is, and I think one of the things that's different in an inpatient freestanding unit is how we treat death. We don't treat it as an awful thing. It's certainly a sad thing, and there's grief assigned to it, but we try to treat it with respect. We have at Casey House what we call a walkout policy, where we cover the body with a very attractive quilt, and we ring a bell as the patient leaves to honor them as they're leaving. And I think the fact that we're all very comfortable with that process makes it much easier for the families. We don't shy away from it.
It also must make it easier for the staff, normalizing something they see every day.
I'm always surprised at the patients and families who are just so grateful to get to Casey House from the hospital, even if they're only there for a few minutes or a day. It is a sigh of relief to come through the doors there. and to be there. And if they pass away quickly, most people families are just grateful to have had that experience. They also have, at that point, they also have access to bereavement services too, to follow up with them for the next 13 months.
And they are so grateful that I know that for many years after their loved one died at Casey House, they continue to donate to Casey House on an ongoing basis. And many of these people are on fixed income. And sometimes their loved one was there for only a day or a very short stay. So what are examples of patient triggers for GIP? Jean?
Pain, again, all of these are things that cannot be managed somewhere else. Pain that despite the treatment that's being given, even in a hospital setting or at home, is not changing it, and we're going to need frequent changes in the medication. And the reason we change the medication quickly is we want to walk the fine line between giving too much medication, curing the pain, but sedating the patient to a point that they're not comfortable with. So we always ask patients and families, what is the pain level you want to get to, and what's your level of functioning that you want to get to, so we can marry the two together. Nausea and vomiting that has not responded to antiemetics or other interventions, complex wounds that need perhaps daily, sometimes more than daily, dressing changes, respiratory distress that is unrelenting, that just is not responding to oxygen and medications that have been given. Sometimes there's a sudden decline in a patient that leads to symptoms that are not able to be managed somewhere else. And certainly imminent death is a trigger if there's connected with that imminent death some symptoms. They're in excruciating pain, agitation that's not being managed where they are. And then that's an example of when GIP is indicated.
We can't stress enough the symptoms. If there are no symptoms, there's no qualification for this level of care. We have a question typed on the chat box saying, would anyone know about what percentage of patients at Montgomery Hospice receive GIP? And what I can say is any given year we take care of 2,500 patients, and not all of them, but maybe 200, 600. About 600 at Casey House, but it's not necessary that hospice at home patients go to Casey House. It's probably not a big percentage of the hospice at home patients don't end up at Casey House because we proactively manage a lot of the symptoms. So most of the Casey House patients come from hospitals.
Mm-hmm.
Hospitals, and sometimes right from home. When we go out to do our admission visit or an info visit, sometimes we just find people in crisis because of their symptoms. And they're so sick that they really do need a higher level of care right away.
Exactly. So I hope we answer your question. And we encourage everyone to continue asking questions. We're not going to go into examples, and we're going to pay attention to this chat box. So don't hesitate to ask questions. We want to make it interactive. So we're going to provide some stories and some experiences from the many patients that we cared at Casey House. So the first example we would like to make it acute complicated pain management. Dr. Coleman.
Yeah. In some cases, people that end up at Casey House require multimodal treatments for pain. I can think of one young man who had an aggressive sarcoma, or cancer basically of muscle tissue, and requiring 2 different medications plus which were being administered. One was given through his IV port. The other was given intrathecally, meaning it was given directly into his spinal fluid to help manage his pain. Plus, he was getting comfort touch, which is a type of touch therapy or massage, to help manage his pain. And eventually, however, his pain became more severe, and we had to move on really to sedation to keep him comfortable until the end. So that's sometimes the kinds of pain management that have to be done. And this is not easily done in some other settings because people are just not accustomed to using some of the medications we use or at the doses that we may have to use them at in order to maintain a patient's comfort and get to their goal.
That's another big part of the education for the staff that is providing, administering those medications. Thank you, Jeff. So our second example about other acute symptom management, Jean?
Things like nausea and vomiting. Sometimes it's not unusual with patients with cancer or even other disease modalities to have unrelenting nausea and vomiting. And again, just like Dr. Coleman said with pain, we look at different ways to take care of that. Because a lot of our physicians and our nurses have been doing this for a long time, there's a lot of collaboration about, have we thought about this? Have we thought about trying this? Again, to move as quickly as possible, but we don't want to add too many things at once because then we're not sure what worked and what we can stop. And again, since a lot of these medications might have other side effects, we're trying to balance those at the same time. Doing all those together is what makes it a challenge.
Mm-hmm. Mm-hmm. Like solving a very difficult, complex puzzle.
Right, and the puzzle can have several of these things. They might have pain and nausea and vomiting and agitation. And so you're trying to figure out how much you can give them and not have to duplicate. And again, keep their level of awareness as high as they want it.
And all keeps coming back to me to training of the staff and knowing how symptoms develop and for some people that are nonverbal as well, right? So our third example is acute terminal restlessness. Dr. Coleman.
Sometimes patients will be out of control at home. These are folks that have issues with, they're just getting up, they're getting out of bed all the time, going back to bed. They may be extremely confused. And when you're talking about someone that may be 85 to 90 years old, their spouse probably is about the same age too, and it becomes very difficult to manage. There could be multiple falls involved. And so that would be an indication for us to use Casey House because that way they have much closer monitoring with someone that is not 85 years old, and so the spouse can be a spouse instead of a caregiver at times. And to make sure it's a safe environment, we may put them in a low bed, put mats out in case they should fall, provide an aide or someone to be there at the bedside. Sometimes they just need someone to talk to them constantly to keep them kind of straight, or to remind them where they are, it's okay. So that would be a typical example of what we have for agitation. Sometimes agitation can be caused by really simple things like constipation, and the nurse will reassess them and find out that they're extremely constipated, give them a laxative somehow. It may be a suppository, an enema, and the person relieves themselves and goes to sleep. So these are the kinds of things that can be done by someone at Casey House.
Mm-hmm.
I think, and when we look at terminal restlessness, sometimes we're really looking at, especially in dementia patients, as they decline in the advancement of their, let's say, Alzheimer's, is they're remembering things that maybe there have been some trauma in the past. So sometimes just being there, having the ability to spend more time with the patient and the family, and letting the family know it's okay, hold their hand, how to deal with this and understand. Many times things are revealed that are shocking, and they do seem, some people just have a lot of what we call unfinished business sometimes. So a lot of it has to do with touch. The aromatherapy really helps. Proper medication, because sometimes there are side effects from the other medicine. So it's knowing how to balance it all out. And it's just important that the family, we also want to take care of the family, that they can then go on with their life and feel like everything was done for them.
And that's what families say. There's one famous note we got that people at Casey House rubbed their arms around the family and wouldn't let go until they were ready. And the family didn't know when they were ready, so they just felt very supported by the staff. So it's as much as we do for the patients, we also do a good portion for the families there, the psychosocial support. So we have an example of acute respiratory difficulties, Sharon?
Well, I think the good doctor, I'll just say my touchy-feely part is that I think that respiratory difficulties are really very frightening for patients. If you've ever been in a situation where you were really short of breath and didn't know where the next one was coming, you get very anxious and then you get even more short of breath. And it's a matter of having the right medications for that disease or why they're short of breath, and realizing that sometimes it is just fear, but also to manage it with more than just a medication. We talked earlier about how we can do high flow oxygen at Casey House. And a lot of these patients that are in the hospital previously that we could not take, and there just really wasn't anything, they were kind of stuck. They had to stay in that hospital setting. And so many patients and families really don't want to be there. And Jeff mentioned about small children. Children to be in a more of a home-like surrounding seem to cope better because if they can see that it's everything in an accepting way, it's a normal part of life. And that's something that sometimes the hospital, through no fault of their own, really just can't handle.
Mm-hmm.
Right.
There are times with respiratory problems. We have taken patients with ventilators. Generally, consider ventilators aggressive treatment for patients, but sometimes families just need a little time, as well as the patients, to get used to the idea of being on it or decide that they don't want to be on it anymore. And so we will do a palliative weaning and remove them from mechanical support such as that. Same with BiPAP. One of the things is I can remember a particular story of a older woman that came in. She was admitted from the hospital, that was on a ventilator. She said she had enough. She signaled to her family she was ready. They actually made funeral plans, and we weaned her from the ventilator, and she was okay for a while. She was still quite ill, but she could breathe on her own, and family kept wondering, well, when is she going to pass away? So, but those are the kind of things we can do. We can at least monitor folks and take care of people that are seriously ill on mechanical equipment.
And our last example about complex wound care,
Right.
Jean?
It's not unusual because remember these patients are already in a very debilitated state a lot of times, and since the skin is our biggest organ, the thought that it's going to fail is very possible. We have a wound champion at Casey House who is skilled in wound care, and she advises us, and we're able to do lots of wounds without a lot of distress about them. We're very used to that sort of thing. Things that would be very difficult to do in any other setting because it takes a lot of time and practice to do it.
Mm-hmm. Mm-hmm. Thank you. Any other comment about examples that we talked about, something that we didn't get to share yet that you can think of?
No, I think the other advantage of Casey House with complex wounds is we like to medicate the patient if we know that it's a very painful procedure. We also look at the wound care. The wound specialist that we have is very good at saying how we can make this simpler for the patient. So we're not putting them through some big surgical procedure, which sometimes that's what it feels like. So they still have the care, because we don't want things to get worse than they are at all possible. But again, it's knowing that the patient's going to have pain, and we're going to take time with it, and we're going to have some medication available so that then the patient can rest.
Yeah, and it's not only oral medications. We sometimes use special gels that may have morphine or ketamine in them to help numb the wound, to give them long-term relief along in the process. Or antibiotics in the wound, really not necessarily to treat the wound, but to cut down on the odor more than anything else, which can be distressing to the patient and the family.
Perfect. So we're wrapping up now. We have 5 more minutes. So this slide is about change in level of care, but not location of care. So what happens when the patient's level of care changes to routine from general inpatient? From the billing standpoint, I know exactly what happens. Our revenue drops from $700 to $150. But can you explain the other dynamics and how to handle this? We need to hand out an ABN to the patient.
Yeah, sometimes once patients' symptoms are settled, it's time for them to move on to another setting, whether it be at home or back to a skilled facility or an assisted living, wherever that may be. And at that point, we have to change them to routine home care, which is a lower level of reimbursement for us. And it also, when they're at that level, that means they're taking up bed space for somebody else that may need from either our hospice at home program or from the hospital, because there's only a limited number of beds available. And so we may have to issue what's called an ABN, or an advanced beneficiary notice, saying that Medicare may not pay for this level of service in the future. And they may also receive a bill at that point from us, depending on the options that they choose. Some families are frightened to take patients home, and we try to provide as much education for them as we can, or as much advice on where to get additional help in addition to the help we provide with our hospice at home program. But still, we will need to discharge them from that setting.
Right, especially at Casey House, where those beds are in such high demand that we really can't make a bed residential. Even if the family could afford paying for it, we can't give them that luxury because there's other patients waiting to take that bed. Correct?
Correct.
Mm-hmm. Exactly right.
So that's important for the audience to know, because I know many of you attending this webinar are referring patients to us, and it's important that you know that that's the way it is.
Yeah, one of the things sometimes we hear is that that someone at the hospital or other facility said you can come to Casey House and stay there until you die, but sometimes just with a little care they don't.
Yes.
Which is, I think, good.
Right.
So,
Right. But the environment is so nice that people
they don't want to leave.
Yeah, they don't want to leave. So we have 2 more minutes to wrap up here. If you didn't type your question on the chat box, please do it now, or you can also email us when we send you other materials. We're going to send you the PowerPoint. We're also going to send you information about how to sign up for the 3 open houses that we're going to have at Casey House in July, August, and September. I'm looking at the chat box to see if we have any questions. No questions at this point. We want to thank our panelists. It was wonderful. There is one question. Are there any plans to open a new GIP in Prince George's?
You never know.
We have to have contracted GIP beds at some point, probably in Prince George's, but as far as a freestanding facility, not at this time that I know of, but if there's enough demand, I'm sure we can find a piece of land and a building.
And people in Prince George's can utilize our Casey House here,
Yes.
right? Which now it's even more accessible with the inter-county connector, so that will be available as well. So thank you very much. We are going to be sending a copy of the PowerPoint to all participants, the dates for the tour, and we are very grateful for your time today. I'm going to turn it to Beza.
Thank you so much, Monica, and thank you for our panelists, Sharon, Jean, and Dr. Coleman, for giving us their time to share their wisdom and knowledge with us. I know we have a few technical difficulties, and thank you so much for bearing with us as we work through them. We do truly appreciate your patience. Now, this webinar does count towards Montgomery Hospice's Certificate in End-of-Life Care. If you're not familiar with it, I know many of you who've signed up for this program are actually candidates for it, so that's great. But for those of you who are not familiar with it, the Certificate in End-of-Life is a very meaningful, affordable end-of-life care training that's well-rounded, taught by professional experts, with hopes of giving you the tools and resources you need to better serve the clients and patients that you see in the community. With that said, if you would like to learn more about what it is, I can send you more information in the follow-up email. Just reply to my email by saying you're interested in learning more about it, and I'll be happy to send you a detailed information. As Monica shared, as a follow-up to this webinar, we would really like you to get a sense of what Casey House look like. It's beautiful, and you would be able to get a private tour, and I have the private tour dates here in the slides listed, but we will also send you a reminder as per usual using Constant Contact, so you can also sign up for it via Eventbrite. And now earlier today you received an evaluation form along with a link to the electronic version, which is something new that we're doing this year. If you can just take a moment to complete that evaluation, it is really helpful to us. It helps us improve our programs. It also let us know what topics to cover next in these series of webinars that we've been providing this year. So Meghna and Mindy, who are my colleagues, are sharing the links right now, so please take a moment to click on it and complete the evaluation. So with that said, as a follow-up, you'll receive the Casey House tour dates along with the PowerPoint presentation, as well as a flyer that would be a supplement to today's program. So thank you so much for joining us. I hope you enjoy the rest of your day, and thank you. Bye.